trends in management of metacarpal fractures. These are learning objectives. We'll review the relevant anatomy and classification of metacarpal fractures, discuss the indications for conservative versus operative management, and explore the current trends in the management of the fractures and complications. This is just the outline of the talk. I did want to kind of define the scope of this presentation. We'll be talking about adult metacarpal fractures of the head, neck, and shaft, mostly of the neck and shaft, and we're going to exclude the metacarpal base fractures and CMC dislocations for another time. We'll talk briefly about thumb metacarpal shaft fractures, but not about the base fractures, the named base fractures. We'll go over some cases, talk about anatomy and how to evaluate these injuries, general treatment strategies, and then head, neck, and shaft fractures, and then go back to the cases at the end. So I'm going to try Nearpod if people can either open up the app or go on to the website. I have a couple cases just to kind of pull the audience and start us off. Seem to be working. EL3GK. All right, so we'll start with the first case. Can one of the residents give a shot at reading this X-ray, please?
Hello. So this is it looks like a right hand X-ray of the AP oblique and lateral. And it looks like for the fifth metacarpal, there's kind of either a high shaft, maybe like 20, 30 degrees angulated fracture of the fifth metacarpal.
Yeah, good. I measured a little more angulation than that. I measured 50, but as you'll hear, that's not obviously, the inter-reader reliability is not great. So here's the first question. This is a 48-year-old male, punched a wall after an argument. He suffered that fracture. He's right-hand dominant, works as a general chemistry professor at Rutgers, no rotational deformity per the ED. You get called at 11 p.m., you're on St. Peter's call. You have to decide whether you go in and see this, reduce it, or tell them to splint it and follow up. So several options. The first three tell the ED to either apply an ulnar gutter, buddy tape the ring and small fingers, buddy tape plus a removable wrist brace. The next, you drive into St. Peter's or bike if you're Jomar, you close reduce it, and you buddy tape it, close reduce it, buddy tape it, wrist brace, AP slabs, and ulnar gutter. Yeah, the code is PL3GK. Okay. So most common, about 28% of people are doing close reduction on our gutter. Next most common is AP slabs. Did have 14% until the ED to buddy tape, putting a wrist splint. 6% buddy tape, close reduce. Okay, cool. So the majority of people are going in to close reduce this. Some others are just telling the ED to follow up. Next case. So this is a similar fracture, kind of a distal shaft, fifth or small finger metacarpal fracture. This is a 28-year-old male, shows up to your office 3 weeks after sustaining this fracture, after punching a concrete wall. He has roughly 55 degrees of apex dorsal angulation. He's right hand dominant. He's still swollen, has a stiff hand with no rotational deformity, and he's neurovascularly intact. Would you A, do nothing and allow mobilization as tolerated, B, no reduction and continue immobilization, C, attempt to close reduction and immobilize in the office, D and E are CRPP, F is using an intramedullary headless compression screw, and G is ORF with plate and screws.
Can you repeat that code again?
Yes, PL3GK. It's on the slides where the x-rays are. These are the films when he shows up in your office. Yeah. The story was he punched a concrete wall on vacation in the Dominican Republic. Okay, so 26% are saying attempt to close reduction and mobilize. We have 13% saying a headless compression screw. 13% saying allow mobilization as tolerated, and then 13% for different forms of CRPP. The majority are saying attempt to close reduction. Case 3. This is a PA oblique and lateral of a transverse midshaft fourth metacarpal fracture. This is a 35-year-old male, showed up to your office 5 days after sustaining this fracture in a hockey fight. He's right-hand dominant. He has a prominence over the ring finger dorsally, is neurovascularly intact, no rotational deformity. Similar options, do nothing, allow mobilization, close, reduce, immobilize, CRPP, headless compression screw, and ORAF with plate and screws. It's the fracture again. So a couple for headless compression screws, a couple for immobilize, a couple for allow motion as tolerated without doing anything. 5 days. Yep. CRPP with intramedullary. Good. Okay. So kind of all over the place too here. Case 4. This is a hand series showing 2nd through 4th metacarpal shaft fractures. The second is kind of a short oblique. The third is the long fingers, more of kind of a base fracture, proximal shaft fracture, and the ring finger is kind of a long oblique. So 64-year-old male, 1 month after sustaining closed 2nd through 4th metacarpal shaft fractures after falling down the stairs. He had been seen in the office previously and attempted non-operative treatment, but is still painful with motion at the fracture site, no rotational deformity and neurovascularly intact. So options here, continue non-op management at 1 month, CRPP, ORAF, headless compression screws, or a combination. Good combination, CRPP, one for continue non-operative management. All right. For the next one, we'll just go through briefly. It was a 14-year-old male presented to ED after a fall. He had this 4th ring finger metacarpal shaft fracture, as well as a small finger metacarpal, proximal metacarpal shaft base fracture, 60 degrees of angulation in the ring finger and 30 degrees in the small finger. He was initially closed, reduced, and placed into AP slabs. So the options here, and I'll just kind of go through these quickly. Remove the splint and allow motion as tolerated. Continue splint, remove it, and put into a fiberglass cast, or fix it operatively. Yep. So here's a reduction. Good. So most people are saying operative fixation. So he never showed up. He presented to the office a month later with these images showing some callus, but continued angulation of these fractures. He has a deformity on his ring finger and small finger, lacks about 30 degrees of terminal extension with no rotational deformity. He can make a fist, but he has weakness to grip strength. So given that most people, actually everyone chose operative management, I assume that A is not an option. We'll see ORIF of 4th and 5th.
But why is A not an option?
Well, A is absolutely an option, but no one picked it initially.
I not, but the guy decided not to have surgery. So
That's fair.
that's probably a bad candidate to operate on.
Point taken. All right, so most people are saying ORIF. This last case, we'll just go through so I can get to the meat of the talk. Bicyclist struck with 3rd through 5th metacarpal fractures. Nerve vascularly intact, closed, reduced, and splinted by the on-call APN. Options, CRPP, ORIF, X-fix, and a combo. Good. So some people are saying ORIF, some CRPP, some a combination of the two. All right, we'll go back to these at the end and kind of see what we did and answer any questions if anyone has them. So just a brief introduction to metacarpal fractures. They account for roughly 40% of all hand injuries. The highest incidence is seen in men ages 10 to 29, and so-called boxer's fracture of the small finger metacarpal neck is the most common. These are generally injuries as a result of a direct blow to the hand or rotational injury with an axial load. Higher energy mechanisms are associated with multiple fractures. Classification, like most fractures, is determined by the location and the type of fracture. You can have metacarpal head, neck, shaft, and base fractures. It can be open and open versus closed, intra versus extra-articular, transverse, oblique, or comminuted. Metacarpal fractures can be associated with a number of other injuries. They can be open with or without significant soft tissue injuries. It can be tendon and nerve injuries. Higher energy mechanisms, you have to worry about compartment syndrome, although it's rare. The so-called fight bite occurs when a bite penetrates the capsule of the MCP joint in a flexed position. Bacteria can then be trapped within the joint as the fist is released from its clench position, so that the bacteria is caught under the extensor tendon and or the capsule. These can often be polymicrobial with alpha hemolytic strep, Staph aureus, or Eikenella, and often necessitate surgical debridement and antibiotics. As with any hand injury, an understanding of the anatomy is integral to appropriately diagnosing and treating metacarpal fractures. They have a unique bony structure. They're concave on the palmar surface. They articulate with the proximal phalanx distally and the carpus proximally. They have a cam-shaped head that forms a condyloid joint with the proximal phalanx. The thumb, ring, and small fingers form mobile borders. The ring and small fingers have about a 15 to 25 degree flexion extension arc at the CMC joint. Thumb metacarpal articulates with the trapezium and acts independently. The index and long finger form a stiff central pillar. The index metacarpal is most firmly flexed and the CMC joints are stable with little motion, and that impacts how much angulation you can accept when treating these injuries. The ligamentous anatomy, the collateral ligaments are important for MP joint motion. In extension, they're lax and they can deviate more radially and ulnarly. In flexion, the collaterals are under tension, which stabilizes the MP joint and improves key pinch and grip strength. The volar plate resists hyperextension, and then the inner metacarpal ligament stabilizes the fingers and prevents shortening with these injuries. Number of muscles attached to the metacarpals. The interossei originate on the metacarpals and insert into the extensor expansion and proximal phalanx. There's 4 DABs, dorsal interossei that do abduction, and 3 pads, palmar interossei that do adduction. The ECRL inserts at the base of the finger, index finger metacarpal. ECRB is right next to that in the base of the long finger metacarpal. ECU and FCU insert at the base of the small finger metacarpal, and FCR inserts at the base of the index finger metacarpal. The ring finger is the only finger with no proximal tendon attachment. This is just a netter's example showing the muscle origins and insertions of the hand. So as a precursor to the talk, just some anatomy useful when evaluating these injuries. Shortening, biomechanical studies have shown that 2 millimeters of shortening can result in a 7-degree extensor lag. The MP joints can naturally hyperextend by about 20 degrees, so up to 6 millimeters may be tolerable with neutral MP extension. Generally, we talk about splinting in the so-called intrinsic plus position of wrist extension and MP flexion. This neutralizes the potentially deforming forces of the intrinsic muscles and prevents loss of MP joint flexion due to contracture of the collateral ligaments in flexion. Pseudoclawing is a phenomenon where you have compensatory hyperextension of the MP joint and flexion of the PIP joint that can occur with excessive apex dorsal angulation. And this picture up in the top right kind of shows an example of that. Malrotation is extremely important when evaluating these injuries. Each degree of rotation at the metacarpal results in 5 degrees rotation at the fingertip, which translates to about 1.5 centimeters of digital overlap in the closed fist. Complete evaluation of metacarpal fractures includes a thorough exam and appropriate imaging. As always, it starts with inspection, careful inspection for open wounds, tendon lacerations, swelling, and loss of a knuckle contour are important. The location of the deformity may indicate where the injury is. Deformity at the metacarpal base may indicate a CMC dislocation. Shortening of a digit may be evident clinically, but is more likely to be noticed on X-ray. Assessing malrotation is of particular importance. As I mentioned, on flexion of the digits, all the fingers should be pointing towards the volar scaphoid tubercle. This can be assessed by the tenodesis effect or having the patient make a fist. Overlap of the digits can be normal in some patients, so it's extremely important when possible to compare to the contralateral hand. As with any fracture, bony point tenderness should be a clue to location of injury. Motor exam should assess the integrity of the tendons and look for any extensor lag that may be present. A neurovascular exam is also key, especially in the case of open fractures. Standard X-ray imaging of the hand is usually enough to diagnose these injuries. These include a PA, oblique, and lateral images. Several special X-ray views should also be considered. A pronated oblique view can give a better look at the index and long finger CMC joint, whereas a supinated oblique view can give a better look at the ring finger and small finger CMC joint. The Brewerton view may be used in the case of metacarpal head fractures and will be discussed later. And a Roberts view gives you a true AP of the thumb. These are examples of how to obtain the Roberts view, where you pronate the hand with the dorsum of the thumb lying on the cassette. On the right, you see examples of how to obtain the pronated and supinated oblique views of the hand. These are particularly important for the residents to be aware of when seeing these injuries in the ED. Oftentimes, you'll have to go with the patient to the X-ray room, and you should know how to get these images to look at those joints. Advanced imaging is rarely needed in the diagnosis of these injuries, but CT scan can be useful in the case of inconclusive X-rays for CMC fracture dislocations, multiple CMC dislocations, or complex intra-articular fractures. So we'll go into specific treatments for the different types, but there's a kind of a general treatment algorithm. Generally, metacarpal fractures that are stable with no rotational deformity and acceptable angulation and shorting may be treated non-operatively. Operative indications in most cases are malrotation, open fractures, displaced intra-articular fractures, unacceptable deformity, or multiple fractures. On the right, this is just a table taken from a recent review article with kind of their suggested overarching guidelines for the treatment of these fractures. As we'll talk about, the accepted angulation and shortening is not always agreed upon. The goal with any treatment of these fractures is stable fixation, early motion, and minimal soft tissue stripping. There's a lot of different operative fixation techniques, and we'll go over them kind of one by one here. So we'll start with metacarpal head fractures and just discuss them briefly. They're rare, usually intra-articular injuries. The index finger is most commonly involved because of its relative immobility of the CMC joint. The small finger is less likely to be involved, given that it has increased mobility and allows flexion so that an axial load is more likely to produce a neck fracture. And the thumb metacarpal head fractures are also rare, as usually the energy dissipates at the proximal metaphysis or CMC joint. This is how you obtain a Brewerton view, which I briefly mentioned earlier. This can be useful in identifying and characterizing metacarpal head fractures. It's obtained by flexing the MP joint to 65 degrees, with the dorsum of fingers lying flat on the X-ray plate and the tube angled 15 degrees in an ulnar to radial direction. The example on the right shows a subtle fracture of the third metacarpal head on the ulnar side there. This is one of the bigger studies I could find about intra-articular metacarpal head fractures by McElfresh and Dobbins. Reported 103 intra-articular metacarpal head fractures in 100 patients. They characterized the fractures by type, found that there's a wide variety of fracture types, with most common being comminuted, ligament avulsions, and oblique fractures. Most of these fractures occurred in the 10 to 29 age range. Roughly 20% of the injuries were open, and they were treated with a wide variety of techniques, which we'll briefly kind of go over now. So the general principles of treating metacarpal head fractures are similar to any intra-articular fracture. Each fracture should be uniquely assessed. Large intra-articular pieces should be reconstructed if possible, and the aim is for early mobilization to prevent stiffness. As with any injury, there are non-operative and operative treatment strategies. Non-operative treatment of metacarpal head fractures should be limited to non-displaced or minimally displaced fractures with little to no articular step-off. These should be treated with a short period of immobilization. Operative options include ORIF, external fixator, MP arthroplasty, and MP fusion. The most common complication of the metacarpal head fractures is stiffness, as you might expect, given the intra-articular nature, which can be due to a variety of reasons. So ORIF is generally indicated for non-comminuted fractures that do not meet operative criteria. Some of the quoted numbers are displaced fracture more than 25% of the surface or more than 1 millimeter of step off. They can be approached through the dorsal approach and usually can be fixed with either headless screws or K-wires, followed by immobilization. External fixation is a good option for comminuted fractures, particularly in presence of associated phalanx fractures. They should also be considered with open fractures that may need surgical debridement or if there's a high concern for initial contamination. Metacarpal arthroplasty can be considered in open fractures and particularly in comminuted fractures with significant bone loss. General contraindications are fractures of the index metacarpal, inadequate soft tissue coverage, or extreme bone loss. While these procedures can be successful in the appropriate situation, they do have a high complication rate, including late failure, delayed infection, implant fracture, synovitis, and stiffness. MP arthrodesis is an option, but really it's only a salvage procedure. Next, we'll move into metacarpal neck fractures. These most commonly occur in the ring and small fingers, with the small finger metacarpal being the most common. Usual mechanism is patients who hit solid objects so that the clenched metacarpal phalangeal joint hits the object and produces apex dorsal angulation. This dorsal angulation is generally the result of impact of the dorsum of the metacarpal head that results in comminution of the volar metacarpal neck. The intrinsic muscles crossing the MP joint lie volar to the axis of rotation and flex the metacarpal head. Indications for non-operative management include acceptable angulation without rotational malalignment. Given the lack of CMC motion at the index and long finger metacarpals, more than about 5 to 10 to 15 degrees is commonly cited as the cutoff for non-operative treatment. Increasing angulation is better tolerated in the ring and small fingers and is commonly reported as 30 to 40 degrees in the ring and 50 to 60 degrees in small finger. However, there are several studies that report good functional outcomes in fractures with up to 70 degrees of acceptable angulation for fifth metacarpal neck fractures. Many of these first numbers were initially based off of biomechanical studies. And as I briefly mentioned before, inter-reader reliability is shown to be somewhat poor and is dependent upon the X-ray angle. Techniques for non-operative management vary among practitioners. Some studies advocate no reduction, depending on the amount of angulation. Other studies discuss blunting and flexion versus extension. More studies advocate for buddy taping with a soft wrap and early motion. Ultimately, though, general non-operative management of these injuries consists of a short period of mobilization followed by early range of motion. There are several techniques for closed reduction. There's the Joss maneuver. There's the modified Joss maneuver. Basically, how these are accomplished is a volarly applied force through the dorsal aspect of the metacarpal, and then a counter force along the proximal phalanx that allows reduction of the apex dorsal fracture. Splinting is generally recommended in the intrinsic plus position, where the wrist is in 30 degrees of extension and the MP joints are flexed to 70 to 90 degrees with the IP joints extended. Although several studies have shown that functional outcomes are no different when splinting in extension versus flexion at the MP joint. This is that study in 2005 out of JBJS. It was a retrospective study. 260 patients in 3 groups were immobilized for 5 weeks. They were all extra-articular metacarpal fractures. The fractures in this study were closed reduced, and then the acceptable angulation was for the shaft, index and long fingers 10 degrees, ring finger 20 degrees, small finger 30 degrees, and neck it was 15, 15, 30, and 50 to 60. So there are 3 groups. Group 1 was the MP joints in flexion with full IP motion. Group 2 was MP joints in extension and IP in extension with no IP motion allowed. Group 3 was the MP joints in flexion with no IP motion. X-rays and range of motion were evaluated at 5 weeks, and range of motion and grip strength were evaluated at 9 weeks. The results showed no significant difference between any of the 3 groups at 5 weeks for either range of motion or maintenance of reduction. And there was no significant difference at 9 weeks for range of motion or grip strength. There's another study that compared buddy taping to plaster immobilization. It's out of emergency medicine literature. There's a randomized controlled trial in patients with an isolated small finger metacarpal neck fracture. Inclusion criteria include closed fractures with an angulation of less than 70 degrees. These were all just 5th metacarpal neck fractures. 2 groups, 97 patients. First group was just buddy taping of the ring and little fingers and versus plaster casting. They similarly showed no significant difference in quick dash scores at 12 weeks or time off work, pain, satisfaction, or an overall health score at 3, 6, and 12 weeks. This is another study, randomized control trial with similar inclusion criteria for small finger metacarpal neck fractures. 2 groups, 68 patients. They compared buddy taping in a soft wrap without a reduction to closed reduction and casting with an extension cast, which was just the preference of the treating team. They similarly showed similar outcomes with dash scores, pain, and satisfaction. With no functional impact of immediate mobilization at 4 months. However, it's important to note that if you're going to try this technique with significantly angulated fractures, that the patients need to be warned that they may lose their knuckle contour. They didn't really, but yeah, I don't think they did too much stratification for that. This was a systematic review of the literature looking at cutoff for acceptable angulation. As I mentioned before, the dogma was that significant biomechanical impact occurred around 30 degrees of angulation for a 5th metacarpal neck fracture. However, they didn't account for compensatory mechanisms of the hand, so there was little value clinically as the argument of this author. I looked at 18 articles and really found that up to 90% of fractures with up to 70 degrees of angulation can be treated conservatively with no reduction. However, reducing it does improve the aesthetic look of the hand. So we talked about non-op treatment of these fractures. How about operative treatment? Indications are unacceptable angulation, which obviously depends on the scenario, any rotational malalignment, open fracture, or pseudo-clawing of the hand. One of the most common techniques is closed reduction and percutaneous pinning. There's a number of different pinning techniques. You can cross pin, which is shown on the top right, either antegrade or retrograde. The bottom left image shows something called bouquet osteosynthesis, where you put wires up through antegrade through the base of the metacarpal, and transverse pinning, where you pin across to an adjacent metacarpal. ORIF is always an option. Specifically, if you can't get the reduction closed, you can still pin even if you do an open reduction. Tension band wiring has been described, and mini condylar plates do exist, although these occasionally have limited utility depending on how distal the fracture is. Headless compression screws have become more common in the last decade, and we'll talk a little bit more about those later. And then postoperatively, usually you're immobilizing these for 2 to 3 weeks and starting range of motion exercises. Complications of these injuries include loss of the knuckle contour, diminished range of motion, palpable metacarpal head in the palm, rotational malalignment, non and malunion, which are rare, but do occur, and pseudoclawing, which I mentioned before, where you have this compensatory hyperextension of the MP joint and flexion of the PIP joint. So we'll go talk about metacarpal shaft fractures. These are classified by fracture pattern. They can be transverse, they can be oblique or spiral, and they can be comminuted. Thumb metacarpal shafts generally occur at the proximal metaphyseal diaphyseal junction, are considered epibasal. Usually they're apex dorsal with the distal fragment adducted and flexed. To get a true lateral of the thumb, you can try to get the MP sesamoids superimposed on each other. And generally quoted guidelines for non-operative management of thumb metacarpal fractures is about 30 degrees of angulation. So for non-operative treatment indications, similarly, there's kind of general guidelines about acceptable angulation and shortening. Really, any amount of malrotation is an operative indication, and techniques like we discussed with metacarpal neck fractures include closed reduction immobilization, and multiple immobilization techniques have been described. This is just a table out of ortho bullets, kind of describing the general range of acceptable angulation for these fractures, which is less in the shaft than it is in the neck. So operative treatment indications, generally multiple fractures, open fractures, bone loss or significant soft tissue injuries, any polytrauma patients, or any patients that are unable to tolerate cast mobilization. Techniques can be closed reduction, percutaneous pinning, intramedullary pin, intramedullary screw, open reduction via a number of techniques in external fixation. This is a busy slide, but it's taken out of greens and kind of highlights the multitude of options to consider when fixing these fractures. The number of different techniques make it difficult to study and have high-level studies comparing each because there are so many variables. K-wires are very useful and can treat almost any type of metacarpal fracture. You can have intramedullary devices, which are generally used for more transverse fractures. Interfrag fixation is an option in long oblique and spiral fractures. ORIF with plates and screws are often used for multiple fractures to give it rigid fixation. And X-fix is always an option for significant bone loss, concern for infection, or adjacent phalanx fractures. So this is just a meta-analysis done recently, highlighting the kind of difficulty of drawing conclusions from studies comparing the different fixation types for metacarpal fractures. There are many papers comparing 1 or 2 techniques, but unfortunately, many of them are somewhat low quality, which makes it difficult to draw conclusions. In this meta-analysis, 9 studies were concluded that compared CRPP to ORIF, and the results showed no real significant difference in long-term dash score, MP range of motion, grip strength, complication rates, or pain scores. CRPP was comparatively higher shortening on X-ray compared to ORIF in this study. This is just a table kind of highlighting the studies a little more in depth, comparing the complications of the pin group versus the plate group, and then residual angulation of each. Complications of metacarpal shaft fractures, similar to neck fractures. You can have dorsal angulation, where there's metacarpal head prominence in the palm. You can get pseudoclawing. You can get dorsal prominence on the metacarpal shaft, which can be aesthetically displeasing, and you can get weakness. Shortening, as I said, is always a concern. Malrotation, stiffness, hardware removal, infection rates are low, but do occur about 1%, and non-union, which some studies define as no clinical or radiographic healing 4 months after fixation, or radiographic fracture line at 14 months, which is more common in transverse fractures. So I'll just highlight a couple studies, a couple recent studies that I found. This was a recent study out of orthopedics that discussed the complication rate of low profile anatomic plates. Historically, ORIF with plates and screws had a roughly 35% complication rate in metacarpal fractures. This study was a retrospective chart review of 79 patients with 110 metacarpal fractures treated with low profile plates. They only showed a 10% complication rate with a roughly 1% reoperation rate, showing that potentially these new low profile plates are much better tolerated than the older plates. Of recent growing interest in the hand community is the use of intramedullary headless compression screws for metacarpal fractures. First case report was described in 2010 and has become an increasingly popular choice for metacarpal fracture management. As reported benefits include early range of motion, lower incidence of hardware removal, and less soft tissue stripping than plate and screw fixation. This was a recent biomechanical study comparing dorsal plating, lag screws, and headless compression screws. They took 5 matched paired hands and used non-thumb metacarpals. Headless compression screws were 3.5 millimeters in the small and ring fingers and 4.0 in the index and long fingers. They tested transverse diaphyseal fractures and long oblique fractures. For the plates, they used 2.4 millimeter low profile plates, and screws were 2.4 millimeter cortical screws. Results of this study showed increased stiffness in peak load to failure in transverse fractures and increased peak load to failure in long oblique fractures. This was a recent meta-analysis in 2019 that looked at 9 articles describing intramedullary headless compression screws. There were a total of 169 metacarpal fractures. 74% of them involved the small finger, 66 were neck fractures, 31 were shaft fractures, and 10 were head fractures. Mean follow-up was 11 months. There was a 100% radiographic union with good MP flexion and total active motion. There were only 9 reported complications, including 4 cases of hardware removal. The authors therefore conclude that this is a safe and effective option for metacarpal fractures that has shown good outcomes. These results certainly sound promising, but some people warn that it may be too early to tell the appropriate indications for this technique. There was a couple comments to this paper published in the same journal. The first acknowledges that intramedullary nailing is not a new concept and that utilizing headless compression screws is a logical choice and makes sense for some metacarpal shaft fractures. However, the evidence is limited, especially in that meta-analysis, to case reports and case series. In one of the articles, there was only 2-week follow-up. In 3 others, there was 6 weeks or less. So there's a question additionally of how much rotational stability these offer. Do they back out over time? What happens if you have to remove them or if you refracture them in a patient population that is prone to refracture? Ultimately, specific indications and long-term safety need to be determined. So there's another comment that argues that it's hard to really draw comparisons to traditional methods that have proven to be very successful in treating these injuries, given that there's a short-term follow-up with no long-term data on the effect of the MP joint. They argue that it should be avoided in comminuted fractures due to possible shortening in osteoporosis or RA. Regardless, headless compression screws are a promising option for treating metacarpal fractures and have good early data. Longer-term follow-up and prospective studies are needed to further elucidate the indications for this technique. So the last study I'm going to review was an interesting study out of the plastic surgery hand world that looked at recent trends in operative metacarpal fractures. I think is a good way to capture some of the general trends and how we've been managing these fractures. So the American Board of Plastic Surgery reported or have surgeons report on 10 consecutive cases with that on patient medical history, preoperative physical exam, operative details, and surgical outcomes are all recorded. The data for metacarpal fracture repair reviewed was from 2006 to 2020. They were separated into 2 groups, 2006 to 2014 and 2015 to 2020. There were 1,160 total cases. 87% of them were closed, 48% were shaft fractures, 24% were neck fractures, with the small finger being most common, followed by the ring finger. There was a pretty good range of transverse, oblique, and comminuted fractures. 34% of these, and these were all operative, had a rotational deformity, with 20% having multiple metacarpal fractures. And there was about 85% patient satisfaction as well as surgeon satisfaction. Anesthesia, general anesthesia was used in the majority of these cases. Local only was used in about 7%, local plus sedation in about 3 to 4%. Regional sedation with like a brachial plexus block was 14% to 9%, and then beer block was about 1 to 2%. Techniques were close reduction and splinting about 10% of the time, CRPP about a quarter of the time, X-fix was rare, and then ORAF was done about half the time. Plates were the most common, followed by lag screws. Perioperative antibiotics were also recorded. In about 22% of these cases, no perioperative antibiotics were documented. 1 dose was given in about 2/3, and then more than 1 in about 10%. Inpatient management of these fractures occurred about 15 to 20% of the time, hospital outpatient about half the time, and then freestanding outpatient center about a quarter of the time. The incision to dressing time was about 51 minutes, and the tourniquet was used in about 2/3 of cases. Adverse events, as many have previously reported, were low. Infection, non-union, and malunion rates were all about 1%. The most common adverse event being decreased MP motion, and about 2% of the time, the hardware had to be removed. So for completeness sake, I'll just touch upon metacarpal base fractures that are outside, really kind of outside the scope of this talk, but stable, minimally displaced fractures can be treated conservatively. It's important to get appropriate imaging at the time of injury, oblique views, and consider a CT scan, and you need to have high index of concern for a CMC dislocation. This was an X-ray done about a week and a half ago of a patient at Robert Wood that was read as just an isolated ring finger metacarpal shaft fracture and did not mention the small finger CMC dislocation. So it's important to look at the imaging very closely. And as a reminder, this is how to obtain a Roberts view and the supinated and pronated oblique. So we'll just go quickly back through the cases here. Case one was this 5th metacarpal kind of distal shaft neck fracture. We had a kind of a wide variety of what people would do. I think most people said they would go in and try to reduce it and put it in some sort of immobilization. That's what I did. I chose AP slabs. Sometimes I do an ulnar gutter. It's kind of just how I'm feeling. Got a decent reduction. Pre-reduction was about 50 degrees and post-reduction 20 degrees. Second case, this was a similar fracture, showed up 3 weeks out from his injury, had a swollen stiff hand. And this was one that was fixed with an intramedullary headless compression screw. So these are just intra-op fluoros showing the guide wire and then final fluoros showing the screw. These are clinical gross photos, top left showing kind of the deformity pre-op, and then inserting the screw and then post-operatively in the small incision. It took about 11 minutes of tourniquet time. Case 3, so this was the isolated ring finger metacarpal shaft fracture in the hockey player. This one was treated with intramedullary pinning. These are fractures a couple weeks out. The pin was removed. This is 2 months later, showing good callus formation. He had excellent motion at this time. And then these are most recent images where he's allowed to return back to contact.
So why on case 2 and 3 did the patient need surgery? Like case 3, what was the issue on case 3? You have pretty good alignment, not terrible angulation, no rotational problem. Why wasn't that just splinted?
Yeah, I mean, that can certainly be an option.
So what do you tell the patient? You're going to have the same result, but you should have a pin placed or a screw placed?
Well, you can tell them that non-operative management is a good option in this injury. However, you do run a higher risk of having kind of a bump on your finger. There's a chance that it could continue, or that reduction could not be maintained conservatively, and that you're more likely to achieve less angulation if you fix it. And if you catch it early enough and they want it done so that they don't have a bump on their finger for sure, then it's reasonable, I think, to fix it.
How long does it take that very transverse, minimally comminuted middle of the diaphysis fracture to heal normally?
To heal completely, it can take months. I mean, it can take a long time. They have the transverse fractures have the highest rate of non-union too. So that would,
yeah, you can sit by and watch those heal forever.
yeah.
And a guy that's breathing down your neck saying, when can I play hockey? When can I play hockey? I think the relative risk of putting a percutaneous pin in that guy, and the reason that I would do it for that guy is to try and, have him heal kind of on time. You're not going to get him to heal any faster necessarily.
Right.
but have him in a good position, have him heal on time, gives him the best chance of not having to go through the next phase of what do we do if it's not healed? What do we do? We don't see any callus. So, it's minimal risk, and I think it, gives a better patient outcome. So that's why he got it.
Yeah. This was the fourth case, second through fourth metacarpal fractures, kind of failed non-operative management, at least at a month, and then was ultimately taken for ORIF with plates and screws. I believe the initial thought going into the OR was try for close reduction percutaneous pinning, but it was unable to get it reduced. I think they started with the index metacarpal, fixed that, and then there was some shortening of the long and ring fingers, so they decided to plate them all while they were there.
So the indication for surgery was pain at 4 weeks?
Yeah.
So is that a new indication, pain at 4 weeks?
No. I certainly an option would be to continue non-operative management to get it to heal. I think at that point, the patient was frustrated with the lack of progress and just wanted to get fixations so that he could have functional use of his hand sooner.
So you're telling me in a short arm splint, he couldn't use his hand, but now with these plates on, he has no splint and he's now perfect?
No, not at all. I mean, he was certainly stiff for a little while, but he did not have a splint on for, I think he was splinted until his first 1 week follow-up, and then it was removed.
You can make a case for anything, and you can certainly make a case as multiple metacarpals, but if you decide on day one, which I think is appropriate, to treat it in a splint, to expect everything to be healed, pain-free, and perfect at 4 weeks doesn't make any sense. So if you're treating it, give it a little bit longer. If you decide you want to fix it, you can make a case as 3 metacarpals. But in a 64-year-old person, another few weeks and the guy would be fine with the same result. You already told us the result's the same no matter what you do.
Yep.
Yeah, I'd have fixed that guy right out of the gate probably. But, again, if you go down that road, I agree with David, follow that course to a reasonable conclusion before you jump the shark.
Yeah. This is the fifth case, showed up in the office at 1 month. Still had a splint on, was taken for a takedown of the malunion and ORIF with plate and screw construct in the ring and small finger. This was 1 month post-op, x-rays showing maintained alignment and intact hardware. He had full range of motion per the note without any pain.
So you did this for a bump, right?
Say that again?
It was healed. You showed an x-ray with callus. It was definitely not aligned properly.
Correct. This was more of an aesthetic.
Did he have any functional problem, or was it just he didn't like the bump?
He did have some stiffness per the note.
He had an extensor lag. This is my case.
I'm sorry, 30 degrees of extensor lag.
Okay, would you expect a 30-degree extensor lag?
In an angulated fracture, 60 degrees? Yeah, you would. Yeah.
Why?
Because, you have kind of a pseudo-clawing deformity so that you lose extension. Because
do most MP joints hyperextend?
Yeah, 20 degrees.
Okay, so we already know, you already told us that you can accept 30 degrees at least in the ring finger of a shed fracture, and the patient's going to be fine. So this is 45 degrees.
I measured at 60 degrees, but
I measured at 60 also.
And a 14-year-old kid with, a 30-degree extensor lag, I think it's reasonable to fix it.
It's definitely reasonable, but you already have a case where it's healed. You're right, you're going to gain a little bit of extension, but is it going to be a big functional difference? Why didn't the kid want to have the surgery right away?
I think
he was 4 weeks out.
I understand that, but
seen by another doctor and they didn't treat him. He was in no splint when he came to see me. So he had been trying to move his hand. And even by the time I got him to the OR, it was another 2 weeks. He still had that extensor lag. So he wanted the surgery so he can open his hand up all the way. I mean, he also didn't like the bump. And we don't have to discount that. I mean, and I think that in this day and age, there's something to be said for cosmesis. You know, I think sitting there and saying it's just for cosmesis, I think it's a different time now and people are less willing to accept cosmesis problems, but that is not why we did this. We did this for his extensor leg and a 14-year-old boy. That's a big deal. And I mean, within 1 week, he had full extension.
Okay, I think is the right thing to do. I just want to make sure that, you know, because some of the cases, clearly he's met the criteria for fixing it. But always look at both sides.
Yeah.
So I think it's very reasonable, but just look at both sides. It's not a bad hand, but you're absolutely correct. For function, it's better, and for the bump, it's better.
You know, I don't know about, go ahead.
Go ahead, Tim. All right, I was just going to, my comment was, I think that I would have done the same thing on the fourth metacarpal. I don't know if I would have used a plate or an intramedullary screw. That is debatable. But my question is, why did you go ahead and fix the fifth metacarpal? That looked to be 4 weeks out and not too displaced.
So, I mean, for me personally, when I was in there, I made my incision right in between the two. I thought it looked more displaced when I was looking at it, and I was already looking at it. I didn't think it was that much harder to fix. He was already under anesthesia. I wasn't sure. He wasn't extending his small finger all the way either, but I just wasn't sure if that's because his ring finger wasn't extending all the way and he just had tethering. So I didn't want to get back post-op and say, oh crap, your small finger is angulated too, because that's a base fracture. So you can't get away with a ton of angulation at the base. You lose that advantage of mobility. So since I was right there, I mean, it was more of a ease and not wanting to have to go back if I was wrong. I think you could make an argument that you don't need to fix it. He was consented for both. I talked with the residents that I wasn't sure what I was going to do up until the operating room time, but I think that would be reasonable to not fix either.
Was there anything wrong with his thumb?
Nope.
No. So that middle view is the normal appearance of the CMC joint?
I mean, it doesn't look it, but he had no thumb pain and he had no mobility problems. But I mean, I don't, you know, that's like kind of a quasi weird oblique view. It's not meant to be a thumb view.
Yeah, Dr. Butler noticed the same thing, but
I mean, some
You know,
people have
the
CMC
point that I
joints
was
that
gonna
look a little
make-
subluxed. I guess you could x-ray the other side if you were curious about it, but he's asymptomatic, so I don't think that it really matters.
I think I don't know about everybody else, but I'm seeing a kind of a rash of people that have been treated in these med-emerges where they think they can just sort of handle it and they don't come to your attention until they're like 4, 6, 8 weeks out. And they've kind of been, you know, mismanaged is maybe too strong a word. I mean, it's, as we've talked about, you can skin this cat in 100 different ways, but now they've kind of forced your hand because it's gone a little bit wonkier than you wanted it to. And something that, you know, we would measure at 60 degrees, somebody else is measuring it at 40 degrees, or maybe they didn't measure it at all. And I think it makes the treatment of some of these a little bit more challenging because of that. I don't know if that's an insurance thing or people just relying on their med-emerges, but I'm also seeing patients that use the med-emerge as their regular doctor. And I'm like, this is sort of a weird world we're living in right now. So anyway, my 2 cents.
this was the last case. 53-year-old bicyclist struck by a van with the closed 3rd, 4th, and 5th metacarpal fractures. He was provisionally splinted by the APN and then taken later that day for CRPP. This was a relatively recent case. He was at 3 weeks out, still had some swelling and stiffness, and then the plan was to remove the pins about 4 to 6 weeks. So just in summary, metacarpal fractures are common injuries of the hand. Evaluation of these injuries must include a thorough physical exam and appropriate imaging. Treatment decisions must account for fracture location and patient characteristics. Non-op treatment is the mainstay for the majority of these injuries, and many different forms of mobilization are acceptable. Criteria for acceptable angulation varies and should be used as a general guide. and multiple operative techniques exist and should be tailored based upon each individual fracture, patient characteristics, and surgeon preference. So I just want to thank Dr. Letty, Blake Coyle, and Monica for their insight in their cases, and the remainder of the hand attendings for helping me on the hand rotation. These are references. Any questions?
I had two comments. One is that was a great review of everything. I just wanted to mention one thing because you quoted an article several times, that article that you footnoted, Strauch and Rosenwasser. That was a cadaver study when you talked
Correct.
about 7 degrees for every 2 millimeters of shortening.
Correct.
Just want, the people listening, that's in the cadaver, that's not in real life. So even though it says in a lab it's 7 degrees, your body makes up for some of that, which is why you can have shortening of at least 6 millimeters. And they also showed in that study that if you fracture a single bone, not multi-trauma, but a single bone, that it almost never shortens more than 5 to 6 millimeters. So shortening is almost never an issue with an isolated fracture.
Yeah, thank you. Yeah, that was the often quoted study in a lot of these kind of acceptable angulation guidelines that has been shown clinically to be able to accept more.
What's the structure that prevents it from shortening more than 5 or 6 millimeters?
So it's the intermetacarpal ligament that really prevents the shortening.
Yeah, sometimes that's an in-service or a board question, the deep transverse intermetacarpal ligament.
Yeah.
Quick comment on my side. There are very few metacarpal fractures that I want to fix that I can't fix with a K-wire.
Yeah.
I know, these other things are nice and they're fancy and they're new and they're typically more expensive, frequently made out of titanium. And I just think that, picking and choosing how you fix it is arguably as important as if you're going to fix it or not.
Yeah.
And, a K-wire is your friend in a lot of different ways. You could put them in 100 different ways, intermedullary, crossing them, cross-pinning across metacarpals. I mean, you showed all of that, and you should really kind of think it through before you necessarily drop a plate on one that doesn't really need that. I mean, if you're doing osteotomies and so forth, you're going to need to hold that in a different way. And so I don't have a problem using plates or screws for that matter, but know your patient, know your situation, and just don't use screws on every single one of those.
Jeremy, quick question.
Yeah, go ahead.
Yeah, thanks. It was great review. I guess my question to the hand attendings you mentioned the JBJS article on immobilization of 5th metacarpal neck fractures. Has that made it through to clinical practice yet? So for the hand attendings on, if you have a 5th metacarpal neck that required reduction in the ER, and then it gets splinted, and then it shows up in your office at 7 to 10 days, what is everyone putting them into for their non-operative care?
Are we talking all metacarpals or pediatric cases? What are we talking?
No, 5th metacarpal neck that was like 60 or 70 degrees, say it was 70, 80 degrees. It required a reduction in the ER. The residents reduced it nicely, put it in a nice splint, and now it shows up to your office for its kind of long-term care. So has this made it to clinical practice yet? Have people gotten rid of the original short arm cast with the MP flex 70 degrees and the IP joints extended?
So I never put that kind of a cast on. Where I was training, we called a Beckenbauer cast on, which just rides a little bit high up on the metacarpal, head area. So you can't really flex the MCP joint, but we leave the IPs free, but we buddy tape them. And so in one patient, if it's a genuine knucklehead, he's getting a cast. If it's another patient that just had I slipped and fell and broke my knuckle kind of a thing, sometimes I'll have the hand therapist make the same thing, but it's a fracture brace and buddy taping. That's what I like to do anyway.
Practice, I know that study shows that you could buddy tape, but I sometimes I think of it like the distal radius studies that say like, don't even bother reducing them, they'll never stay. But you look at the results here, and I don't think that those really fall for distal radius fractures. And I personally think that's true for metacarpal fractures here. And after being other places, I could tell you that in Pittsburgh, they didn't even try and reduce them, or they didn't even or if they did try, it was like a really half-assed try. And then they would be like, oh, well, they don't stay. And it's like, well, I mean, why would it ever stay if it's not in a good splint? So I still tend to cast them. I put on the cast that Dr. Letty just said, kind of a high riding short arm, and then buddy tape the fingers, probably because that's what he taught me to do. And I think it works really well. You just kind of make little indents where you want the pressure to kind of hold it back. But that's me personally. I'm not sure I believe that study 100% when it's being well reduced to begin with.
If the resident reduces it nicely and it comes to the office and it maintains whatever reduction and the patient wants the best possible alignment, I usually keep it on for 3 weeks and then they're done. If it settles back down, then they have to decide whether they want to accept a bump or no bump. Most people accept the bump. Sometimes you can re-reduce it. But it's really, if the patient doesn't care what his hand looks like, you can put him in an ace bandage and let him do what they want.
Yeah, Steve, you ask each of us, you're going to get a different answer. But I've had a problem at 7 days where I've taken it off and then tried to recast them, especially in flexion. One, because they're painful, because you need to push volarly to kind of hold that reduction. And I've actually lost the reduction with trying to get empty flexion. This study says it doesn't matter. And I think it was Shin's paper from the Mayo group, and Tim can correct me, but they had a nice series where they did that Beckenbach cast and they did the MP and extension. That's easier to hold the reduction. And that's another way to go. So I was telling the residents, if you are going to reduce it, I like that Beckenbach way. And like Dave said, leave them in this orthosis for 3 weeks, and then they're probably done. In all honesty, though, if somebody has a markedly displaced fracture, it looks better with the reduction, I'll probably talk to them about surgery. And I'm one of those guys that's doing more of those intramedullary screws. I've just had great success with it. They move it right away. So I'll certainly talk to them about surgical fixation.
Brian, tell us all what the cost of that screw is.
That's a good question. It's a good question that I don't know, but my gut would be about $700. But I will say, and again, I'm not the, there's a lot of things I do that probably could be, cheaper. But I will say, and I've said
That would be one of
times
them
now, that sometimes when you put pins in, patients are reluctant to move their hand, and then they'll need some therapy afterwards. So the increased cost of that screw may be 3 or 4 physical therapy visits, which I typically don't have screws doing therapy. I typically have pins do. So this is where big data would be really helpful in looking at the overall cost. And then pins also have some complications. You look at Letsky's paper, and I think it was like 30% of patients with pins had complications. Do you leave them in? Do you leave them out? Do you give them antibiotics? There's a lot of things that happen there. So it's not cut and dry. It's just what's the cost of the screw.
All right, just so the residents keep in mind that a K-wire costs $3.50. Almost all of them could be out by 3 weeks, maybe 4 on a transverse fracture. And almost all of them, I'm talking about neck fractures or shaft fractures, almost all of them could be left out of the skin and pulled out in the office. I don't remember ever sending anyone for therapy because you can move their IP joints right away. But I don't know the cost of that screw, but I would say you're probably right, 700 to 1,000, but I don't know.
Was a study I came across that was in that ballpark. I think it was around there. I'll try to send you the paper.
Yeah, I want to make one other comment because both David and Brian had touched on it. And it's a problem in my particular office. So, sometimes you get a guy that comes in and he's been splinted by, one of the residents, and it's like the perfect splint. And it's perfectly reduced. You're looking at the x-ray and you're thinking, oh, this is going to be a chip shot. And you walk in the room and the splint is on the table already. And the nurse is taking it off and she's trying to help you move along. And you're like, oh, shit, I was almost there, just needed to leave that splint on. So, yeah, I think when you can do that, that's optimal. If it's already been reduced and it's in a good splint, there's nothing better than that. And so I try and, jump the shark on those when I can and get in there before the nurse takes the splint off to send them for x-ray. So be aware of that, because that can be a great way to manage, a fracture that your best opportunity to reduce it is, the first one. It's in the ER. You could get a really good reduction because there's not usually a whole lot of swelling. The delayed ones are more difficult, but When you can, that's a great way to manage them.
Well, thank you, everybody.
Nice job. Thank
Good.
you.
Good job. Nice review.